Hello all, and welcome to the Graded Passive Mobilization Lecture. This is what our outline will look today. I will be responsible for going into depth with 1 and 2, Introduction and Definition, as well as Cavitation. So what is HVLAT? Well, HVLAT stands for High Velocity, Low Amplitude Thrust. A thrust is considered high velocity, low amplitude therapeutic movement with or at end range of motion. Specifically, HVLATs are techniques designed to restore motion to a joint exhibiting a restricted range of motion. If we look into Maitland's work from 1997, he describes grade 5 mobilizations as an HVLAT, meaning occurring at end range, high velocity, low amplitudes. For the purpose of this lecture, I'll be using HVLAT, grade 5 mobilization, and manipulations interchangeably. We'll see how the APTA, as well as specifically the California Physical Therapy Association, defines and uses these terms. Let's take a look at the APTA's positional stance and terminology. In 1998, the APTA published the Guide to Physical Therapy Practice. In that practice guide, they specifically mentioned that manual therapy techniques comprising a continuum of skilled passive movements to joints and/or related soft tissues at varying speeds and amplitudes, including a small amplitude, high velocity therapeutic movement. So they specifically addressed the high velocity, low amplitude movements in their manual therapy techniques. However, in 2014, the APTA Guide to Physical Therapy Practice greatly generalized the meaning of manual therapy. In 2014, they noted that manual therapy techniques are skilled hand movements and skilled passive movements of joints and soft tissue. They don't mention small amplitude, high velocity therapeutic movement, but they do include that techniques may include mobilization/manipulation. Another resource the APTA published in 2013 was an educational resource paper. The purpose of this resource paper was to show that HVLTs are a skilled intervention, specifically should only be completed by a physical therapist and not by a PTA. They specifically state that HVLATs emphasize that these procedures are applied on a continuum. They require ongoing examination and evaluation to determine how to proceed along the continuum, with modification of speed, amplitude, and direction of forces for optimal clinical outcomes. Therefore, you're constantly reassessing the situation, and this requires a skilled provider or practitioner to complete this. Let's look at what California has to say. Well, California is even more general than the APTA, the national APTA is. They don't mention anything specifically about HVLATs or manipulations or even mobilizations for that matter. They specifically define physical therapy as means the art and science of physical and corrective rehabilitation or of physical or corrective treatment of any bodily or mental condition of any person by the use of physical, chemical, and other properties of heat, light, water, electricity, sound, massage, and active, passive, and resistive exercise. It shall include physical therapy evaluation, treatment planning, instruction, and consultative services. The practice of physical therapy includes the promotion and maintenance of physical fitness to enhance the bodily movement, related health, and wellness of individuals through the use of physical therapy interventions. So very general from the CPTA Practice Act. Well, you could say Chiropractic care is very similar to physical therapy, high velocity, low amplitude thrusts. And the case is, you're correct. But let's dig a little bit deeper into the philosophy behind a chiropractic adjustment and a physical therapy HVLAT. So I think the best analogy before breaking into chiropractic adjustment versus PT HVLT is think of acupuncture versus dry needling. They're very similar mechanisms. However, there's different philosophies between acupuncture and dry needling and why each of the types of practitioners do what they do. It's similar for the chiropractic adjustment versus the PT HVLT, VLAT. Specifically, a chiropractic adjustment follows the philosophy of the subluxation complex. According to the Association of Chiropractic Colleges, it defines this subluxation complex as follows. A subluxation is a complex of functional and/or structural and/or pathological articular changes that compromise neural integrity and may influence organ system function and general health. Basically, the Chiropractic Association is stating that a subluxation affects all systems of the body in a sense. The subluxation complex is broken into 5 primary components: kinesiopathology, neuropathophysiology, myopathology, histopathology, and pathophysiology. Basically, all of these components show the effects of a subluxation and how it affects all other systems of the body in respect to movement, the neural system, the muscular system, physiology, and eventually resulting in pathology. Let's contrast this to the physical therapy HVLAT. I came across a quote by Joe Walter. He's a master's of physical therapy, and I think he expressed the difference in philosophy between chiropractors and physical therapists extremely well. He states that physical therapy, HVLATs, it's not an adjustment. Physical therapy specifically utilizes spinal and extremity manipulation in the treatment of neuromusculoskeletal pain and dysfunction in order to restore mobility within these systems. We, PT, do not utilize manipulation to manage, co-manage, or prevent diseases or conditions in other body systems. That is in direct competition or direct contrast to the chiropractic subluxation contrast, in which they state that an adjustment is going to be effective in improving the other systems of the body. Again, a PTHVALT the goal is to restore mobility through neurophysiologic or musculoskeletal mechanisms, specifically in the musculoskeletal system. We want to improve mobility. That is our goal. So, what's been going on in between the chiropractors and the physical therapists? We know that, again, the mechanisms and the outcomes are very similar with a chiropractic adjustment versus a physical therapist HVALT, or manipulation as it's typically called in the literature. And because of these similarities, there is quite a bit of turf battles between the two different types of providers. Let's take a look at what Dunning published in 2017. He looked at the 1980 California Department of Consumer Affairs, or the DCA, statement of the ruling. Specifically, the California Department of Consumer Affairs, of DCA, wrote in 1980 that they do not believe that a physical therapist is practicing beyond his or her legal scope of practice by utilizing such technique. In our opinion, meaning the DCA, the performance of joint mobilization by a physical therapist is not the adjustment and manipulation of hard tissues as a chiropractic technique. We primarily view this controversy not as a matter of legal interpretation, but an interprofessional squabble, often referred to as a turf battle. All right, in 1980, the DCA said that physical therapists can continue to manipulate their definition up to interpretation. Okay, let's look at something a little bit more recent, specifically in California, since that's where we will be practicing during your residency. In 2013, the CA Senate ruling said, according to each profession's scope of practice, it is in fact appropriate for both professions to teach these exercises. All right, so according to the CA Senate ruling in 2013, we're both allowed to use the practice of manipulation. It's a bit confusing though, however, because what are we supposed to document when we do a HVLAT or similarly a grade 5 mobilization or similarly a manipulation? What terminology do we use on a day-to-day basis? Well, there are no clear guidelines. Legally, we physical therapists can complete manipulations and use the term manipulations in our documentation. You'll see it's also widely utilized in the research. Unfortunately, there's always going to be turf wars. Chiropractors and physical therapists most likely will always battle to get consumers, to get patients, to get customers, and a big draw for patients can be if a provider can do these manipulations or if chiropractors can complete their adjustments. And so our professions will continuously fight each other to gain the rights to these terms. So there's a question for you to think about. You are an independent practitioner at this point. This is your license. And it really comes down to, do you want to fight the fight? Do you want to fight the fight or not? As a general sense, if you use the term manipulation, it's used by both professions. Yes, chiropractors may also use the word adjustment, but they also use manipulation. This may draw the attention of the chiropractic board to you. If you, for instance, are running a private practice saying you do manipulations all the time, that's going to draw attention of the chiropractic board. However, if we use the term grade 5 mobilization, it's more closely tied to a physical therapy database, aka Maitland's terminology. It's more directly linked to the physical therapy profession and will most likely draw less attention from the chiropractic board. So it might be, in a sense, safer to use the term grade 5 mobilization or an HVLAT. But we can use the term manipulation. It's just how comfortable you are with the terminology and knowing the philosophy behind it. Okay. Moving on to cavitation. Well, specifically looking into the physiology of cavitation, refractory period, and the necessity of cavitation. Okay, according to Kowchuk in 2015, joint cracking is associated with cavity inception rather than collapse of pre-existing bubbles. So in previous literature, the hypothesis had been that the sound or the cavitation, the pop, occurred when the bubble collapsed. However, in 2015, a new paradigm was made in a sense that the sound was actually coming from the bubble inception or the cavity inception. This was tested in the hand. However, we'll get into some later research to see if there is that carryover into the spine itself. So according to the more current literature, how does the physiology of a cavitation actually work? Well, first, there's the rapid separation of joint surfaces. There's a drop in synovial pressure. This allows dissolved gas to come out of the solution, and it creates a space. When this space is created, that's your crack, that's your cavitation. And when the gas is reabsorbed, the space disappears. Again, this was completed in the hand and not in the spine. However, this is the current literature that we are working from. It is important to note that there are other philosophies or other theories as why cavitations can occur, especially if we hear different types of sounds, different refractory rates. So this cavity inception is not the only theory out there, but it's the most prominent one and the most proved one at this time. Here we can see cavity inception, real-time visualization of it at the MCP here. So you can watch and you'll see that there is a space between the two bones that occurs, and that is at the point of bubble inception or the cavitation. That's when you would hear the pop when you see the separation of the two bones. So as I've noted, the formation of gas bubbles has yet to be proven with zygapophyseal joints. It hasn't been proven in the spine. According to Casicoli in 2003, there was no evidence of gas in the joint space or obvious increase in the zygapophyseal joint space with immediately after the manipulation. This was evident in both the traction and traction-free post-manipulation scans and plain film images, and specifically it's not consistent with the current understanding of the cavitation in joints, in particular the refractory period. So we don't really know if the theory of the gas bubble inception carries over to the spine like it had been shown in the hand so prominently. So this comes from Casicoli's publication in 2003, and here he looked at the space created after a manipulation was completed at the spine. These are two of the tables, and if you look down the slide, you can see pre-manipulation versus post-manipulation, and there really isn't any significant difference in the two sides. So, again, no clinically significant increase in joint space following manipulation in the spine. Okay, let's talk about the refractory period. So typically, once you're cavitated, once you hear that pop, and you'll see it with patients, especially since you've been practicing, you can't get another pop immediately after. Well, why is that so? The theory is that microbubbles in the synovial fluid have not been reabsorbed, and when you recavitate, the gas expands, preventing sudden drop in the intra-articular partial pressure, and you can't hear the crack until the gases are fully reabsorbed. Unsworth in 1971 gave more specific time frames. So on the left-hand side of Table 2, time related to the crack. And then on the right-hand side of this table, of Table 2, is joint separation. So before the crack, or at rest, there was 0.98 millimeters of separation in the joint. At the crack, there was 2.5 millimeters, so at the crack, cavity inception makes it bigger. It stayed until 5 minutes. Again, the gas bubbles are not reabsorbed. 10 minutes, still, it's almost back to normal, 0.99. And at 15 minutes, according to Unsworth's, the joint separation was back to its resting state. So theoretically, he should have been able to recrack the hands. Again, that's where they tested the cavity inception after 15 minutes. However, in 2008, Berezunic completed a very small study of 3 participants. Basically, they completed lumbar manipulations in the spine over and over again until they came back to a baseline state with different time frames between them. What they found is that the refractory period was 40 minutes for subject A, between when they could hear a cavitation again, 70 minutes for subject B, and 95 minutes for subject C. and the average refractory period following lumbar manipulations across the subject was about 68 to 33 minutes. So that's why the cavitation time ranges from about 15 to 90 minutes, 15 being more applicable to the cavitation in the hands, and longer periods of time having to do with cavitations in the spine. Still, the jury is out on whether the gaseous inception occurs in the spine. So, do we actually need a cavitation? Well, honestly, the jury's a bit out on that. There is some literature out there, which we will go over next, that shows that cavitations aren't too much required. The sound isn't required for an effective HVLAT, but there's a lot to think about with these studies as well. So Flynn in 2000 published the audible pop is not necessary for successful spinal high-velocity thrust manipulations in individuals with low back pain. Okay, his conclusion, there is no relationship between an audible pop during SI region manipulation and improvement in range of motion, pain, or disability in individuals with non-radicular low back pain. All right, let's look at another one. Flynn also published in 2006. He published the audible pop from high-velocity thrust manipulation and outcomes in individuals with low back pain. What did he find? Again, the results of this study suggest that a perceived audible pop may not relate to improved outcomes from high-velocity thrust manipulation for patients with non-radicular low back pain, either at immediate or longer-term follow-up. That's another no for is a cavitation needed. All right, Thorup in 2020, this was a recent one. Thoracic spine manipulation did not improve maximal mouth opening in participants with temporomandibular dysfunction. Okay, his results show there's no difference in treatment response over time was observed between the groups. So unfortunately, it did not improve the patient's TMJ pain. Okay. Bialowski in 2010, the relationship of the audible pop to hypogeusia associated with high velocity, low amplitude thrust manipulation, a secondary analysis of an experimental study in pain-free participants. What was the conclusion? Again, the current studies suggest hypoalgesia is associated with HVLA manipulation and occurs independently of perceived AP. Inhibition of lower extremity temporal summation may be larger in individuals with whom an AP is perceived, but further study is necessary to confirm this finding. So they're basically saying that the POP may be important, but further studies are needed to confirm, and that the hypoalgesia does not necessarily directly correlate with the sound of the cavitation. Let's look at our RCT by Silvas in 2011. Immediate effects of the audible pop from a thoracic spine thrust manipulation on the autonomic nervous system and pain, a secondary analysis of the RCT. Again, conclusion. The results of the study provided evidence that the presence of joint sounds does not influence the overall activity of the autonomic nervous system following a thrust manipulation or contribute to the reduction of pain in patients with chronic neck pain. Okay, so unfortunately all the previous studies show that cavitation is not directly linked to improve outcomes. Well, let's look at a systematic literature review. This was published by Horn in 2018, relatively recent. The regional effect of spinal manipulations on the pressure pain threshold in asymptomatic subjects, a systematic literature review. So what they looked at is how manipulation affected the pressure pain threshold in subjects. Asymptomatic subjects, so that comorbidities and chronic pain central sensitization didn't come into play. Well, what did they find? Well, manipulation has an effect on the pain pressure threshold. Okay, so it has an effect on the PPT. They found that when a manipulation was compared to a sham meaning that they put the patient in the same setup of the manipulation, but an audible cavitation was not heard, the manipulation had better outcomes. They also found that manipulations had better outcomes than an inactive control, so they did nothing. But, unfortunately, related to the previous studies we just looked at, they didn't see a significant difference between manipulation versus mobilization, meaning grade 4 or lower, and other PT interventions, Therax, soft tissue mobilization, stretching, etc. We can dive a little bit deeper into this breakout here. So, to orient you, on the very left-hand side, that is the author. The second area here, area of SM or spinal mobilization, where they completed it, was it regional? And then the last group of columns shows what was compared. So the green boxes right here basically show that the manipulation was superior to what was compared to it. So if you notice, all the green boxes on this slide are manipulation versus sham. And like we said in the initial conclusion statement, manipulations have a better effect over a sham. The red boxes show that there wasn't a significant difference of manipulations over mobilizations or other types of physical therapy. Same thing as seen here. The green boxes show that manipulations had better outcomes versus the red boxes did not. And you can see there's actually quite a bit of red there, showing that the manipulations did not have better outcomes than the other situations. Manipulations, again, including the cavitation. Okay, let's look at a systematic review and meta-analysis. This one comes from Coronado in 2012, Changes in Pain Sensitivity Following Spinal Manipulation. So this study shows that the mechanism of a spinal manipulation remains elusive. It appears to modulate pain through both central and peripheral pathways, and that it demonstrated a favorable effect over other interventions on PPTs. There's a potential influence on higher levels within the central nervous system. So nothing was too concrete here, but basically what we got out of it was that the manipulations again, including the definition of a cavitation, affected the central nervous system. These are the studies looked at in this systematic review. And the aforementioned studies demonstrate that manipulations affect pain thresholds and may influence the central nervous system. That's exactly what the conclusion stated. So if we take the definition, manipulation, which includes a cavitation, can we make the connection that a cavitation is required? Thinking through it like this. All these studies showed that a manipulation had an effect on the central nervous system. If a manipulation includes the definition of a cavitation, is it required? Well, if you follow the scientific method, no, not really. It's not required. But if we think of it from a clinical perspective, when there's a lot of different variables, a lot of different unknown, and we kind of jump to conclusions, which again is not the scientific method, clinically applicable, clinical finding, possibly yes. Here's another question. So back in Unsworth's paper in 1971, he showed that if a cavitation was not heard, if there was no crack, there was no jump in separation in joint space. So one could ask, if we orient yourself here, on the left-hand side, we see the dotted line in the bottom is relatively linear and straight, and then all of a sudden, at 10 kilograms of load, there's a crack, and then there's a jump in joint space separation, the cavitation. On the other side, there was no crack, and we show that there was never a change in separation of joint space. So one could ask, if there was no cavitation, we know there's no separation in joint space, especially in a joint separation. Was the bubble created? And if the bubble wasn't created, or if there wasn't a quick separation in the joint cavity, was there reduced neurophysiologic effects due to the reduced speed? Something to ponder. Another important aspect of cavitation, the beliefs in the population about cracking sounds produced during spinal manipulation. How we think about a cavitation, or how we think about a manipulation, can be extremely powerful. We know our brain is capable of a lot, and so if a patient expects that a cavitation or a pop will make them feel better, even if it's placebo, that is very strong leverage. Similarly, if you as a practitioner think, hey, this is going to make this patient feel better, if I hear a cavitation, they will feel better. Your energy, your thought, your perception on the situation can carry over to the patient, and hence they believe it too. So in this study, what they basically found was they asked participants what they thought that the sound meant. The sound was mistakenly considered to indicate successful spinal manipulation by 40% of participants. So 40% of the people said that if they heard the sound, they'd get better. And so we just have to take that into account, that patient perception and even therapist perception can possibly play a large role in whether a cavitation has an effect on the patient's pain and disability. A couple clinical pearls for you. If you decide you're going to complete a manipulation or a HVLAT or a grade 5 mobilization, patient buy-in is essential. Again, the human brain is very strong, and if they're not totally on board with the situation, if they don't believe that pop is going to make them feel better, it very well may not. And so I would highly recommend the patient is very much on board for this situation. As previously said, a cavitation has a strong effect on a patient's psyche. If he or she is nervous or apprehensive about the manipulation, I would recommend don't manipulate, or plant the seed and come back to it and try a little bit later. But through my clinical practice, doing a manipulation or HVLAT on an anxious patient usually does not turn out too well. And again, clinically, I've noticed that my patients seem to experience a greater reduction in symptoms when a cavitation is heard versus when it doesn't. So just things to think about. Thank you for listening to me today. Here are your references,